Today we are looking at anaerobes and pseudomonas and opportunistic infections. So anaerobes, obligate anaerobes are bacteria that cannot survive in the presence of a high oxidation reduction potential or redox potential and high oxygen content. During metabolism, bacteria can produce toxic byproducts from oxygen, including superoxide radicals and hydrogen peroxide. Strict anaerobes lack certain enzymes, including superoxide dismutase and catalase, that can detoxify these products. So polymicrobic anaerobic infections. Strict anaerobes cannot grow in healthy tissues due to the oxygen content. When tissue injury occurs of limitation of the blood and oxygen supply, conditions are created for opportunistic growth of obligate anaerobes. Often more than one species will infect the same site. Simultaneous infection of a facultative anaerobe, which uses up already diminished oxygen supply, also encourages growth of obligate anaerobes. Most anaerobes in the normal flora are non-spore formers, and anaerobic infections often occur from this source. However, contamination of wounds can also occur with anaerobic spore formers, and examples of Clostridia, which are common in environments such as soil. Non-spore formers rarely produce exotoxins in contrast to spore formers. Strict anaerobes are present in large numbers in the intestine, 95 to 99% of total bacterial mass, but also in the mouth and general urinary tract. The most common infection resulting from abdominal surgery or other gut injury are Enterobacteriaceae, facultative anaerobes, and Bactericidis fragilis. These are minor components of the gut flora and demonstrate the important point that certain organisms more readily produce opportunistic infections than others. So there are problems in identification of anaerobic infections. They are often derived from the normal flora. One must be confident that one is not isolated a contaminant. If air gets into a sample during sampling or transportation to clinical laboratory, then the organism may not be isolatable. Slow growth of the organism due to inefficiency of fermentation means isolation takes several days or longer. Systems are commonly used to identify anaerobes: biochemical systems and/or gas chromatographic identification of volatile fermentation products, short fatty acids or chains and alcohols. So let's have a look at some examples of anaerobic non-spore formers of clinical importance. So you have gram-negative rods such as bactericides, Bacterophilarides and Fusobacterium. Gram-positive rods such as Actinomyces, Arachnia, Eubacterium, Bifidobacterium, Lactobacillus and Propionibacterium. Gram-positive cocci such as Peptostroctus and Peptococcus, and gram-negative cocci such as Veillonella and Pseudomonas. Let's have a look directly at Bacteroides fragilis. So Bacteroides fragilis is important strict anaerobe non-spore former causing clinical disease. It has a prominent capsule that is involved in pathogenesis since it is antiphagocytic and directly involved in abscess formation. Anaerobic spore formers such as Clostridia, these are gram-positive rods and they are found in the environment, particularly soil, but also intestinal man. So here is one example: tetanus caused by Clostridium tetani. Clostridium tetani is a gram-positive rod that forms a terminal spore and is commonly found in the soil, dust, and animal feces. Contamination of wounds which provide anaerobic conditions can lead to spore germination and tetanus, which is relatively rare in Western countries but frequently fatal disease. Infection usually occurs when spores in dirt, feces, or saliva enter wounds and scratches where they germinate and produce tetanus toxin. Puncture wounds such as by a needle or nail, other wounds and scratches and burns can lead to C. tetani infections. More rarely, surgical procedures and dental extractions can lead to tetanus. Tetanus can also be contracted from the use of intravenous studs. The organism is non-invasive and remains in the local wound. The exotoxin tetanospasmum binds to ganglioside receptors on inhibitory interneurons in the central nervous system, in which glycine is commonly the neurotransmitter. This stops nerve pulse transmission to muscle, leading to spastic paralysis. The toxin can act at peripheral motor nerve and plates, the brain, spinal cord, and also in the sympathetic nervous system. Because inhibitory neurons are involved, the result is unimposed muscle contraction. In generalized tetanus, the most common form, the patient typically experiences lockjaw. This is a stiffness of the jaw muscles that results in inability to open the mouth or swallow, leading to the appearance of a sardonic smile. Speech as a result of spasm of the vocal cords may be affected. Continued severe muscle contractions, which can even cause broken bones and resulting spasms, often lasting for minutes over a period of weeks, can be fatal. The patient often experiences headaches and/or a fever with sweating, elevated heart rate and blood pressure. Tetanus patients in hospital often experience nosocomial infections. Aspiration pneumonia is often a late complication. On average, about 8 days after infection, symptoms of tetanus appear, though the incubation period can be as short as 3 days and as long as 3 weeks. The incubation period seems to depend on the distance of the infection site from the central nervous system. In neonates, the average latent period is about a week. There are also other forms of tetanus, such as cephalic tetanus, which is a rare infection involving the middle ear. It can affect cranial nerves. Local tetanus is also rare and manifests itself as localized muscle contractions in areas of infection, though few of these cases are fatal. Vaccination of infants with tetanus toxoid have almost eliminated this disease in the United States. The toxoid consists of tetanus toxin has been inactivated using formalin to stimulate antitoxin antibodies. This comes in two forms, precipitated and fluid. Precipitated form yields more rapid seroconversion and higher antitoxin titers. If infants receive a complete vaccination regime, virtually 100% protection is achieved. Boosters should be given every 10 years. Diagnosis is clinical and bacteria only derived from wounds in a minority of cases. The treatment is an emergency situation which requires hospital. The patient is immediately treated with human tetanus immune globulin or equine antitoxin. Drugs can control muscle spasm and the wound requires aggressive washing and treatment with antibiotics. Gas granulin Clostridium prevengens. So Clostridium prevengens is a gram-positive rod which causes wound colonization, gas granulin after soil, and to a lesser extent intestinal tract contamination. It is primarily seen in time of war as a result of non-sterile field hospitals and projectile wounds. The term gas granulin refers to swelling of tissues due to the release of gas and fermentation products of Clostridia. Progression is toxemia and shock is frequently very rapid. Gas granulin can easily be identified by the large blackened sores and loud and distinct sound caused by gas escaping from necrotic tissue. It is a moist gangrene in contrast to dry gangrene, which is not caused by bacterial infection. This organism produces several tissue-degrading enzymes, including lucifanase, alpha-toxin, proteolytic and saccharolytic enzymes. Necrosis and destruction of blood vessels in the surrounding tissue, especially muscle, result in myonecrosis, which is a condition of necrotic damage specific to muscle tissue. This creates an anaerobic environment in adjacent tissue and the organism spreads systematically. Death can occur within 2 days. Nowadays, treatment including antitoxin, antibiotic therapy is extremely effective, and amputation and death is rare. The determination of production of lecithinase is important in the laboratory identification of the organism. This bacteria is also a significant cause of food poisoning by enterotoxin producing strains. Botulinum. So botulism is a real but fatal form of food poisoning. It's caused by a potent nerve exotoxin such as botulinum toxin. Besides food poisoning, C. botulinum can cause wound botulism, which is even rarer than botulism food poisoning. In addition, iatrogenic botulism can occur from accidental overdose of botulinum toxin. C. botulism does not readily grow in the adult intestine due to competition for the normal flora and the requirement for an anaerobic low acidity environment. After eating contaminated food, the symptoms of botulism occur usually within a day or two, but sometimes there may be a period of up to a week before they appear. Vision and swallowing are affected and the patient may become nauseated and constipated. Muscle paralysis ensues, usually starting at the head, and when the respiratory muscles are affected, death can result. While the bacterium does not grow in the adult large intestine, it can in infants who ingest spores or ubiquitous in the environment. Eating honey contaminated by spores is one source. Also, an early symptom is constipation and general malaise. With muscle paralysis, swallowing becomes difficult and paralysis of the head muscles leads to characteristic floppy baby symptoms. Impaired respiratory muscles lead to breathing difficulties and possibly death. When severe wounds are infected, the conditions are right for the growth of Clostridia, leading to similar symptoms of foodborne botulism, except the gastrointestinal tract is not involved. So look at treatment. Treatment for adults include enema to clear the GI tract of the toxin and injection of antitoxin. It is important that antitoxin is given early to neutralize the toxin and protect nerve endings from damage. So the antibodies produced for antitoxin are in the horses. The horse-derived antitoxin is not used in infants who receive instead human botulism immune globulin. Antibiotics are not used to treat botulism, although they may be used in secondary infections because of the possibility of more toxin being released as bacteria are lysed. Supportive treatment of infants is based on helping them breathe and on tube feeding. Adults may also require a respiratory and possibly a tracheotomy and intensive medical and nursing care for several months. Death from botulism has become much rarer in the last wee while. Some patients die from infections or other problems as a result of being paralysed for weeks or months. Patients who survive an episode of botulism poisoning may have fatigue and shortness of breath for years, and long-term therapy may be needed to aid recovery. However, complete recovery from botulism usually occurs over a period of months as the damaged nerve endings are replaced. Let's look at Clostridium difficile. So Clostridium difficile is frequently known as nosocomial infection. The organism is a gram-positive rod and causes a variety of diseases, including pseudomembrane colitis, which is a form of gastroenteritis, toxic megacolon, perforations of the colon, sepsis. Patients who are at increased risk of having this are ones that have received antibiotics, total pump inhibitors, gastrointestinal surgery, manipulation, long length stay in healthcare settings, and serious underlying illness. Those at immunocompromised conditions and advanced age are also at high risk. However, it's important to note that Clostridium difficile infection is rarely fatal. So symptoms: when a normal flora of the intestine is altered by antibiotic therapy, this organism, which is present in the gastrointestinal tract of many babies, can grow and colonize C. difficile. So C. difficile produces an enterotoxin, and pseudomembrane colitis can result. Symptoms include abdominal cramps and watery diarrhea. Some starts 4 to 8 days after initiation of antibiotic therapy. In mild cases, there is no blood in the diarrhea, but in severe cases, bloody diarrhea, a distended, tender abdomen, and fever can occur. Treatment therapy includes discontinuation of the implicated antibiotics, such as ampicillin, and severe cases require specific antibiotic therapy, such as vancomycin. Let's look at Pseudomonas aeruginosa. So Pseudomonases are aerobic gram-negative rods of polar flagella. They are oxidative positive in contrast to Enterobacteriaceae. These organisms are found mostly in environments including water and the soil and air. Among the genus Pseudomonas, the majority of human infections are caused by P. aeruginosa, although other related organisms can also cause disease. Normally, individuals with compromised immune systems, such as those affected with HIV, organ transport recipients, and burns patients, are particularly prone to Pseudomonas infections, and mortality can be high, as much as 90% in heart infections. In burns and wounds, there's the structure of blood vessels which limits access of phagocytes that would normally clear the region of the pathogen. Cystic fibrosis patients are also at risk of infection, since alteration of the respiratory epithelium commonly allows colonization development of pneumonia. This is often seen in children who may suffer recurrent bouts of Pseudomonas pneumonia, resulting in fever, wheezing, productive cough, distended abdomen, breathing difficulties, and cyanosis. This is often accompanied by weight loss. Pseudomonas are opportunistic pathogens. Nosocomial infections by P. aeruginosa are particularly common in intensive care units and can lead to fatal pneumonia, in which the patient has a productive cough, chills, breathing difficulties, and cyanosis. The problem is compounded by the often encountered resistance of Pseudomonas to common antibiotics. Moreover, the slime layer that is produced over the surface of these organisms has an antiphagocytic effect, making the control by the immune system of phagocytes difficult, yet they stick readily to other cells. They also produce tissue-damaging toxins. Infections by P. aeruginosa are a common cause of bacteremia. This is bacterial blood infections. Heart valves, particularly intravenous drug use, can also be infected. Symptoms include general malaria with fever, joint and muscle pain. Pseudomonas can infect the skin as a result of bathing in infected waters, resulting in itchy rash in otherwise healthy individuals. This is the so-called hot tub folliculitis. Sometimes these skin infections can be severe and result in headaches, sore eyes, stomach and breast, and earache. Injury can lead to infections of soft tissues and of bone and joints, and the bacteria can also spread to these sites for bacteremia. Bone involvement is sometimes seen in diabetic people as well as people who are undergoing surgery. Infections of wounds can result in a characteristic fruity smell and blue-green secretions. Among other pseudomonas-caused infections are those of the urinary tract, often as a result of catheter use or surgery. The brain, which can develop abscesses and meningitis, and the eyes and ears. Swimmer's itch is an innocuous infection of the ear canal by these bacteria, but older patients can experience life-threatening infection of the ear, which sometimes cause paralysis of facial muscles. Abrasion of the cornea can lead to infection and resultant corneal ulcers, which, if left untreated, can cause severe damage and loss of sight. Some eye medications and prolonged use of soft contact lenses can exacerbate the infection. Identification of pseudomonad infection includes the pigment production phyocyanin, which is blue-green, and fluorescein, which is green-yellow fluorescent, and biochemical reactions such as oxidase test. The cultures are fruity smell, and since hospitals are so commonly infected with pseudomonads, the presence of the organism is not sufficient to prove a source of infection. Techniques such as X-rays can be used to assess deep tissue and bone infections. So there's a problem with resistance of pseudomonads to various antibiotics. Two such drugs simultaneously often employed for up to 6 weeks, either by the mouth or intravenously. Eye infections are treated with antibiotic drops. In the case of infections of deep tissue, such as the brain, joints, or bone, surgery to remove the damaged tissue may be required. Moreover, amputation may be necessary in infections of the limbs of burns patients or those with infected wounds. Toxicity of pseudomonas results from the production of toxin A, which ADP, adenosine diphosphate ribosylates elongation factor, and is EF2, which is used in protein synthesis. So in this, Pseudomonas toxin is similar to diphtheria toxin.